Okay, so today we're going to be talking about chest wall pain. We're going to specifically looking at the essential illness scripts for some of the conditions in this area. On the next slide, we'll be looking at how I've divided them for this presentation. Okay, so I've divided this into two parts: posterior pain and anterior pain. It's partly about where the pain is felt, but it's also about the causes of it. So there's no real quick dividing line, except probably on the cause of it more than anything else. But it's a bit loose. It's just one way of dividing this up. So under posterior pain, I'm talking about fractures, which of course can occur anteriorly, but most of these are going to be posterolateral. Discogenic pain syndrome, which again, of course, can refer around the chest, but the source of it is at the back. Segmental dysfunction, same thing there, and we're going to include ribs and facet joint problems here, and of course, central stenosis. On the anterior aspect, we'll be looking at referred pain, both somatic and neuropathic, cardiogenic and viscerogenic pain, mostly cardiogenic, though this is a more important one, obviously, and then osteochondritis. Okay, so anterior chest pain. Now this is going to be the least common area of pain you're going to see in the thorax, obviously. What you're going to see mostly is posterior pain, not anterior. This is also the one you want to be most careful of because almost all heart attacks have their symptoms anteriorly. It's only the atypical ones that either don't have chest pain or have it posteriorly. So let's look at cardiogenic pain now. I'm not going to include visceral with this simply because if the pain is viscerogenic in nature, then you know it's visceral. Otherwise, you're going to confuse things like esophageal reflux and so on with the heart, which isn't a bad thing. I mean, you always err on the side of the heart being a problem rather than the esophagus. So we'll concentrate on the heart. I'm also leaving out of here diaphragmatic tears. These are extremely rare. There will be a sudden onset, same as any muscle tear, and it can be felt depending on where exactly the tear is, but it can be felt anteriorly. It'll be lower thoracic. Anyway, looking at cardiogenic pain, the typical angina, which is an ischemia rather than an infarct, is the pain is substernal and it spreads out from below the sternum, can go up to the jaw or the neck and into either or both arms. It's felt more as a heavy pressure rather than a severe sharp pain. These pains, the sharp pains are if it's coming from the heart, are coming from a myocardial infarct rather than just an angina. Somebody who has angina will know the difference usually anyway, unless you'll see in the first episode, which is really going to be peculiar. So there's no real mistake in this. They're going to tell you they got this problem, if they even bring it up. You also have the cardiac decision rule that we looked at in the last video. As I say, 3 out of 5 of those items, and they want to be referred to the emergency room. You can have an angina equivalent, which is signs rather than symptoms, and these are considered, as the name would suggest, equivalent to actually angina pain. So even without the chest pain, these symptoms are such. And we're looking at mostly shortness of breath, extreme fatigue, and pain in any other area in the upper quadrant, that the torso area anyway, and the shoulders, in patients that are high risk for heart attacks. On the negative side, when you do a musculoskeletal exam, the range of motion should be pretty damn good, and the PAs are going to be negative. So you shouldn't have too much trouble sorting this one out. Atypical cardiac problems include sharp pains, fatigue, nausea, sweating, and angina equivalent signs. These tend to be more common in women than men, and it also occurs in elderly people. Blood pressure can go up or down or remain unchanged during actually a heart attack or an angina attack. But my suggestion is you do a blood pressure reading anyway. If it looks elevated, it's another reason to refer them to the emergency room if these symptoms are ongoing. Okay, costochondritis. I've left out Tietze syndrome for a really good reason here. Tietze syndrome seems to be costochondritis, but with swelling or thickening around the junction, whereas costochondritis is considered the same as Tietze syndrome, but without the swelling. So essentially, these are the same thing, but in Tietze syndrome, you have this thickening or swelling. That thickening and swelling can last for years, sometimes forever after an attack. But it looks as if the causes of these and the treatments are the same thing. So there's not that much difference between them, so I'm going to include them all under costochondritis. It's often used in terms that you often use interchangeably, but there is that separation of the two in medical literature. However, what you get is can be extremely severe anterior pain right over the junction, and there's obviously going to be tenderness there as well. The patient's going to be reporting on pain on forced respiration, usually expiration with coughing and sneezing and so on, but forced expiration as well. So heavy exertional exercises bring us on either because of the movement, the extreme movements are occurring in the area, or the heavy breathing that accompanies this. As I say, there's no swelling with costochondritis, but there will be with Tietze syndrome, and the swelling is visible and palpable. The only things that can really get mixed up with would be something like pleural pain, intercostal tears, and then your palpation is going to take care of this, obviously. There's going to be pain over the costochondral junction with costochondritis. That should be there with pleural problems, although range of motion may be a problem with pleural, and upper limb movements can be a problem with pleural problems. And with intercostal tears, that's a matter of palpating accurately, missing the costochondral junction, dealing with the palpating the muscle. It's worth looking posterior on these patients. Sometimes if the rib is jammed up posteriorly, or if the joint, the facet joint, is jammed up posteriorly, then that can put stress on the anterior area, and away it goes. Outliers here is a severity of the pain. It can be extremely painful all the way down to quite minor pain. And the degree of tenderness is going to go along with that, as will the patient's reaction to exercise and deep respiration. Yeah. Okay. Referred pain. This is probably what we'll see anteriorly more than anything else. The big thing with referred pain, and the sources of it is going to be radiculopathic pain, and spinal or costal joints causing pain, segmental dysfunctions causing this referred pain around fractures, arthritis, etc. All of these can refer pain around the chest. So the pain can either be somatic when it is one of these musculoskeletal structures, or it can be neuropathic when it's radiculopathy, in which case it's likely to be lancinating type pain. The commonality between them all is that there is a topographical connection between the referred pain and the spine. In almost every case, there'll be a few where this is atypical, but these will very much be outliers. It will be related to spinal movement and positioning, and also PAs are going to be positive. Okay, and so to posterior thoracic pain, obviously the one you're going to be dealing with much more often. First off, let's look at fractures. These could be pathological or stress fractures, or they could be healthy bone fractures. In common, they're going to have a sudden onset of the severest pain the patient's going to feel. Now, with a healthy bone fracture, that is going to be absolutely severe. There's no doubt about this. It's going to be really quite severe pain. With pathological stress fractures, it depends on how much stressing has gone on or how much pathology is present as to how severe the pain is. But nonetheless, when the fracture occurs, it will be at its worst. It won't get worse over time, unless they're doing something really stupid to it. So as far as stress is concerned, the big pathological problem here is osteoporosis. These are not very thick bones at the best of times, and osteoporosis takes its toll on them. As far as stress is concerned, it's generally speaking chest infections, where the patient is doing a lot of coughing over a prolonged period, and that can weaken the rib. Now, why it weakens one particular rib, I don't know. It may be there's a dysfunction at one end, so it can't move as well as the other. I really don't know, but it does seem to do exactly that. These tend to be isolated fractures. The With severe trauma, it depends on how many ribs are hit during the trauma, but there's obviously going to be post-traumatic, sudden onset, severe pain. Now, if we're talking about, that's a rib, if we're talking about the vertebra being fractured, this is not really going to be a healthy bone fracture. Or it's going to be very unusual if it is. Most thoracic fractures are either going to be pathological fractures where you get collapse, or the fracture is so severe it generally damages the spinal cord, so you don't see them. But either way, whether it's a vertebral fracture or a rib fracture, healthy bone fracture, you're going to have extreme tenderness either in the midline if it's vertebra, or along the rib if it's not. Given all that, there's probably no need to stress the rib, but if you are going to stress the rib, compress the fracture, don't shear it. All right, so you just have to grab around the rib this way and just push those two ends in over that fracture site and see if it's painful. But generally speaking, you don't have to do it. The differential diagnosis for this is going to be a intercostal tear, and the way you tell the difference between the two is by palpation. Careful palpation will tell you it's the muscle or the rib that's fractured. You can get intercostal tears with the fracture. Obviously, the rib can fracture, displace a little or a lot, and actually then tear the intercostal muscle. In which case, the rib is the obvious issue, but the tear can show up later because you're going to get scar tissue and adhesions and everything else, and that can be a source of ongoing pain. And again, this comes down to very careful palpation. The same tests are there for a stress fracture, careful palpation, compression if you have to, and so on. So these two have something in common. The difference is the seriousness of the fracture, the trauma causing the fracture, and also how much pain is generated. Otherwise, it's much the same thing. Disc herniations, we talked about those in some detail, and essentially I'm going to use what's the convention of assuming this is going to turn out like a cervical or a lumbar disc herniation. What discogenic pain looks like that isn't a disc herniation, I really don't know. But if we're looking at the EIS spin similar to the lumbar spine, it's going to be severe pain. And the difference now is about 40% of these patients seem to not have pain as their presenting complaint, in which case the presenting complaint is going to be neurological. It's either going to be a radiculopathy or more likely it's going to be a myelopathy. There will be extensive referrals, so this one can go all the way around the chest. And there will either be or not be a radiculopathy or a myelopathy associated with it. These are extremely rare events, so if we're looking at 1 in a million, this doesn't happen very often. You're looking at, if 1 in a million is about correct, I don't know how many adults there are, but let's say there's 200 million adults in the States. This means that only 200 people in the US have a radiculopathy or a myelopathy from a disc herniation. You'll have impairments of both flexion and extension, and all ranges of motion will be limited, and of course your PA is going to be very painful. Central stenosis, it's going to be similar to cervical and lumbar stenosis as far as presenting symptoms. So you're going to have a central bilateral aching pain across. How far it radiates bilaterally is about the severity of the pain more than anything else. PAs are going to be stiff over it. There may or may not be a myelopathy. You might find the patient complains of tripping much the same as they do in the neck, so that there may be no neurological symptoms except this tripping. It's well worth looking at for reflexes and so on, and also making sure the tripping isn't due to balance. So test balance, and then you can do, because this is probably for abnormal fatiguing of the dorsiflexor, you can go along and try testing both feet to see if they do lose it. In this case, the extension loss is going to be more than the flexion loss. Okay, so posterior pain for viscera and cardiac problems. There may or may not be viscerogenic pain. It's very helpful. It is, because that's all you really need to send this out. If it is lining pain, pleura, pericardium, and so on, then this can be a much sharper locomotor type pain. It's unrelated to local range of motion unless this is pleural. the pleura attaches to the rib, so when you move the rib by looking at range of motion, the pleura gets stressed, and that can be painful. PAs are negative though, and you're looking at this saying, what the hell's going on here? You really can't find enough musculoskeletal to convince yourself you've got a real problem. Okay, systemic arthropathies. It's unexplained arthritis basically, and you really don't want to allow unexplained arthritis to go on. Multi-levels are going to be affected. Rib expansion is going to be reduced. The most common systemic arthropathy is going to affect this area, of course, ankylosing spondylitis. So multi-levels will be affected. Your PAs are going to show this when you do this. Rib expansion is going to be reduced. Schober's test should be positive. There isn't much on the sensitivity specificity numbers on Schober's. Everything seems to be reliability, which doesn't interest me in the least at the moment. But Schober's test should be positive, and it's supposed to be less than 5 centimeters or less, and you've got a positive test. And then, oh, by the way, ankylosing spondylitis is not confined to men. All right, this affects men and women, and particularly women with a wider disease base, such as Reiter's or Crohn's disease. This is usually part of it when it's called a reactive arthritis, but essentially it's the same disease. Okay, segmental dysfunction. The patient will complain of sharp pain and dull pain, the same as they always do. But the pain is going to be moderate. These are short duration episodes of this. The intensity and referral are both moderate, as I said. Flexion or extension dominated, non-obligate impairment, and flexion or extension range of motion loss, and the PA should be appropriate for the condition that you're looking at. Now we've covered EISs for segmental dysfunction, so all of the outliers need to be considered as well. Okay, so there you go. That's EIS for some of the conditions you might get involved in. There are obviously many more conditions in the thoracic spine, but most of these are rare. Trauma causing fractures and so on are the commonalities, and segmental dysfunctions. After that, everything drops down. I can't remember anybody ever, I've never seen one as far as I know, a radiculopathy caused by a lateral stenosis. I'm not even sure I've seen a lateral stenosis with these people. So you won't see too many different presentations other than segmental dysfunction, such as from the rib or from the facet joint. So I hope that helps, and I'll talk to you again. You take care, everybody. Bye-bye.